Okay, we have a very exciting guest today. I feel like we have wanted to do this podcast on hormones for a really long time.
Yeah, I've got a lot of burning questions.
Yeah, got a lot of questions. Yeah. We've got Dr. Jennifer Zelovitzky on the podcast today. Welcome.
Hi, thank you so much for having me.
Thanks for coming on.
No, I'm just so excited.
I thought you were like trying to signal something
I'm
to me.
I'm trying to be like cool about it because I have all like the things that I want to ask, but I'm like trying to wait for you to do your thing.
Okay, you want to wait for the little intro.
Yeah.
Okay, so I met Jennifer. Well, actually, we first met virtually.
Yes, we did.
On a call, because for those of our listeners who don't know, I have been dealing with menopause for the last 5 years. So when I was 25, I was diagnosed with the BRCA gene. And then I had my prophylactic double mastectomy as a response to it. And then when I was done having my kids, I had my ovaries removed. Not thinking too much about it, because I think when people are diagnosed with BRCA, at least in my situation, I was like, oh my God, my breasts. That was the thing that was like, you know, that I felt was going to be sort of like had the most impact on me because it's
also,
such a...
And with kids, you were very much like, let's go.
Totally.
Right? Because you were like, in terms of, you were like, if I know this is happening, everyone's like, well, Lauren's on a very quick journey. And I was like, honestly, girlfriend, like I would never kind of explain it because it's never, but I was,
yeah. Why did you have kids so quickly?
No, and that's true. Like I always remember you considering that, right? Because you were like, at some point, I'm going to have to consider doing that. And
yeah. And for those that don't know, BRCA basically puts you at a very, I think 70 or 80% greater likelihood of having breast and ovarian cancer.
And ovarian, yeah.
Compared to the rest of the population. So I had my breasts removed. I had my ovaries removed after I had Zach back in 2016. Did not think much of it. I was like, let's get rid of them. This is a silent killer. I just want to get this done because of my chances of developing it. And I remember at the time, my GP was like, oh, you'll just go on the pill. You'll just go on the pill to even out your hormones, and they will just, you know, they'll stabilize everything and you'll be fine. Again,
the pill or the mini pill?
The pill. Didn't think anything of it. Yasmin, whatever it was, whatever I went on. And then I saw another doctor shortly after, and she was like, no, let's get you off the pill. Put me on something else. And I'll fast forward because this is a very long intro, but my hormones have basically been out of whack for 5 years. I was put in touch with you.
And what are some of the stuff you've dealt with your hormones? Because I know this has been such a struggle, right?
Yeah,
like different things like
mood swings, night sweats, hormonal acne, hair loss, skin laxity, like all this stuff that you're just like, well, this is not cute. This is not cute. And I was not expecting this.
Right.
So, but I feel like my hormones have felt out of whack for so long. I was put in touch with Jennifer, who works at Medcan now, and spent like 2 hours talking to her. And I was like, I love you. You seem so knowledgeable, because I've met with so many different people in all different areas, functional medicine doctors, GPs, specialists. And I just hadn't really connected with anyone. And I felt like you knew your shit, just to put it bluntly. Like you, okay. You knew your stuff.
Her energy is very low. Like she's just very like, yep. Like I like it. It's a matter of fact. She's like, you're just. It's
well,
good.
I want to interject just to say, like, it's not that some of those other specialists don't know what they're talking about. They don't have the luxury of time that I'm fortunate to have at Medcan with my clients to explain things.
Right.
It's sort of like, this is what you have. Here's your prescription.
Right.
And on to the next, because
you're tight for time.
There's so few providers who are specialists, and they are overwhelmed.
Right.
Okay, so for free, you get it right now on the podcast. Here we go.
Yeah.
Okay, we can.
So anyways, that was a very long intro into how I met you, but you basically chatted with me, and I just immediately felt like you were so knowledgeable that our listeners would benefit from this conversation so much, and that I just wanted to have you on talking about hormones, all about them, imbalance, how to measure them, how to deal with them.
I don't think anyone even thinks about their hormones until they go, like, unless someone like you're PMSing, or unless you're one of those kids where you have really bad period cramps, or like you need to stay home from school and like all that kind of stuff. I don't know. I had chill periods. I never thought about my hormones once until I was trying to get pregnant.
Right. And a lot of people, their moms don't talk to them about the perimenopause or menopause
Oh, no,
transition.
but like it's just kind of like, well, or they're not like they're not had it gone through it yet. They're starting to now, and it's just
Right.
like, yeah, it's I don't know, it's just not top of mind, I guess, or something I've naturally be interested in. But then your body starts to change, and you slow down, and you actually start to think about things a little bit more. At least that's what's happening with me, and I'm like, huh, like I kind of want to get to know why this is happening, or this is, like just understand your own personal situation so much more.
Absolutely. So I'll tell you a little bit about my background is as a family physician. So I trained as a family physician. And one of the things I want to say very bluntly is we did not learn anything about the menopause transition in family residency training. This is a big shock to people. So when you go to your family doctor and they just don't really know how to navigate this with you, or they may fob it off a little bit, like it's just, you just have to get through it. It's just part of life, which is what I hear time and again from my patients. Part of it is that they just don't have the tools. This was not a part of our training. That goes back to a lot of the Women's Health Initiative study, and I'm sure we'll get into a little bit of where this distrust came from and this fear of hormone replacement. But it was only after I completed my residency that I started training to do my work at Sunnybrook, working with young gynecological cancer survivors who were in menopause, that I started learning about this. And I became sort of self-trained as a certified menopause practitioner and went and did my certification earlier this year. So now I'm fully certified as a menopause practitioner. And the number of aha moments that I had through my training was quite staggering, because I couldn't believe I'd been in practice for nearly a decade and I didn't know any of this stuff.
Okay, quick question. How long was the training for the hormone,
It's self,
like a,
believe it or not,
Yeah.
to become a menopause certified practitioner through the Menopause Society, it's self-directed. So when you're ready to sit the exam, you study, you get their textbook, their guidebook, you look at all of their position statements, you look at all the guidelines. For me, a lot of it was working with patients and learning on the go and studying from people like the specialists at Mount Sinai. And when I felt ready to sit the exam, it was a bit complicated. I was supposed to sit it last year, but we had a death in the family. So I postponed it, and I wrote it this year, but I'd already been practicing. So for all intents and purposes, I had already been doing this.
Right.
It's just a question of having those credentials so that I can say to my patient,
right.
I have the same credential in menopause training as your gynecologist.
Right.
There is such a need for this service.
More understanding of
I
it.
would strongly encourage anyone who's interested more in learning and going in this direction. It's obviously so badly needed.
Okay, so let's hear about why. Because I feel like for me, for example, like my skin was like a porcelain baby. I looked like my skin growing up was like, it was so beautiful. And I didn't have pores. And then I was 25 and I was hit with horrible hormonal acne, like cystic hormonal acne. And it was the worst. It was like, all we want to do when you're in those moments is figure it out. And that was like my first realization. Didn't matter if I had dairy or this or that. There was like shit going on, right? That I needed to balance out.
And who did you go to about that?
I was in New York,
approach?
And I was like, kind of, the system there is so different in the States. So I kind of popped into whoever I could see, but on my plan. And what they put me on, this was pre-kids, pre-marriage, like when I was 26, after being on birth control, just for like preventative reasons my whole life. I went on this medication called spironolactone, which is like a heart blood pressure medicine that they put me on. And like nobody had really heard of it at the time. And I had to go in every month to check my potassium levels so it was like really interesting, but it worked instantly. And that was like the first sign of like, this was a medicine that was created to lower blood pressure, but then they found in turn really helped with women and their hormones and balancing out. And I have high levels of testosterone, which is really cute. And for whatever reason, it just worked.
Exactly.
And so
that's why it worked, because I don't know did they explain to you why it was going to work?
But there was no other, like, it was like this, she was like, try this before you go on like an Accutane or something else because, and it was like a little bit unconventional and I hadn't heard of it, but it was a good dermatologist in New York. And I was like, and I did, and it worked. And I had like beautiful skin for my wedding. And it was such a saving grace because I know how horrible that is. But then I tried to get pregnant and I had to go off everything. Your birth control, your skin, like you have to go off everything. And then that's when the rock and roll happens. Like either you get like glowing skin when you're pregnant or it's horrible or post. And then for me, it was with the miscarriages, it was up and down, up and down. So that's when that was my journey with hormones. It was like very much like, I'm an adolescent. I don't want to get pregnant. I've got bad skin. I want to fix it. But like, how do we make ourselves, make your daughters, make the women of the world, like kids, everyone more knowledgeable about this so that you can be better informed?
This is just what it is. It's having that knowledge from a reliable source.
Right.
So you don't want to just go on a deep dive on Facebook or your aunt, whoever, who says her friend did this or whatever. You want to actually go to a reliable source. Just to throw a few out, but places like the Mayo Clinic, they have amazing resources online for you to get reliable information about your health. And what you want to do is learn as much as you can about your own body and about physiology. So the ovaries start to produce hormones around the time just before puberty, and the ovaries actually produce estrogen, progesterone, and testosterone. Right? We have a few sources of the so-called androgens, which we think of as those male hormones. And that's what drives things like the acne or the facial hair, or things that women sometimes get. I'm not saying you have facial hair, but I'm saying for some people,
we've dealt with it.
For some people, that's
the amount of threading and waxing and lasering we've done to.
Right. And so we can presume that for people who struggle a lot with acne, for whom spironolactone helps, they probably have an imbalance where they have more androgens than estrogens, or more androgens than we would ideally want, or more androgens than their body can metabolize. And therefore, the spironolactone works because it reduces the androgen levels. It works for whatever reason as an anti-androgen. That's why in your case, it worked. Right. For some women, the birth control pill works beautifully. Right. It balances things out. It keeps the levels of estrogen and progesterone really stable in the body. It sort of suppresses the ovaries, so you're not getting these crazy fluctuations every month.
And are you born, like, is it a set of hormones that everyone is predisposed to genetically? Like my mom, say, had higher estrogen versus this than I am?
I think there is some genetic predisposition, like most things in life, but I don't know that anybody's actually done a ton of research in that specific area. Like most things in women's health, no one puts any funding into it, which is why so little is known, so little is done, and so little is taught.
Why? Really? Just in Canada, there's not a lot of...
I'm going to tell you an interesting fact.
Okay, let's go.
Until 1993, women were, for the most part, excluded from clinical trial participation because they didn't...
In Canada?
Everywhere. The doctors didn't want the hormonal fluctuations to be impacting
the results.
Oh my God. So they had men because you
of what
don't
type
have
of
to worry
testing,
about any
everything?
Of this. All sorts of clinical trials.
Like for like any
all
type
kinds
of
of medications. So cardiac medications, not birth control pills per se. That would probably be the one exception where they let women participate. But so most of what we know now, and then in 1993, they're like, yikes, we better let some women in because we need to see some real world examples of these medications. And this is why we're sort of extrapolating a lot. When we prescribe a heart medication to a woman, the data is largely based on trials that involved men. Right. And
that's crazy.
It's actually really sad.
So as medicine's progressing and as research is progressing, where everyone's kind of taking a step back and saying, wow, women have really been left out of the picture. We need to do more. But more, there's so much more to be done. So little of the research, I think it's around 3.5% of all research dollars in Canada go towards women's health subjects or topics.
Which is crazy because what is the population? It's obviously somewhat in the middle.
And so the
doesn't add up.
Yeah. So the fallout from that is we have a generation of women who are now like, okay, you told our mothers they just had to suck this perimenopause up or these hormonal changes up. We're not going to do that anymore. What I love is women are so open about it. The fact that we're having this conversation, I don't know that this would have happened 15, 20 years ago.
Yeah.
Yeah.
Well, I think there's also a huge stigma around menopause that it's like literally like your grandma's issue, or you don't have to deal with that till you're 50 or 60. I'm obviously a specific situation because of the BRCA gene, and I voluntarily had my ovaries removed. But there are so many like of my friends who I know who are in their 40s that are experiencing symptoms not dissimilar to mine, who don't have the gene, who haven't had their ovaries removed. And like, maybe we can talk a little bit about that, because when we first sat down before the cameras turned on, we were talking about hormone balance and like, what is it to have hormonal balance? Does that exist? Can you achieve it? And what did you tell us? You dropped a bomb on us as soon as you sat down.
Yes, I had to drop a bomb because it's a myth that your hormones can be quote unquote in balance. You are never going to have a stable level of hormone, at least not in the middle part of your life where you're active and thriving and having children and going through perimenopause. They're fluctuating by the day, by the hour.
What's perimenopause?
So that's a great question. Let's go back a little bit. Okay. I'll start with what is menopause, because that's simple.
Because like you already just like made it like a peri, and I'm like,
this is not a well understood, and it has to be well understood. We have to own our bodies, right, as women.
Well, because I was just going to say, I think so much of this, to your point, is reactionary. We're not doing the information because unless you need to do something, you're not going to think about it.
Exactly. Exactly.
Because you need to fix something, but so much more should be taught because it's important to just understand. Like it is that when you get sick, when you do, you know what I mean? So it's to me, this is basic health needs for women.
Yes. Yeah. And a decade ago, women in their 40s were also experiencing this stuff. They had no idea what it was.
Yeah.
They thought they had a million different things wrong with them. No one just said, oh my gosh, it's perimenopause.
They're like, you're a witch.
Yeah.
You're a witch.
Or to your point, you're a woman. Deal with it. Deal with it.
You deal with it. You deal with everything else. Deal with this too.
Okay. So explain to us. So menopause and peri. Yes.
Menopause is a moment in time. It's one moment in time. I know it's become this, term to describe the whole rest of your life after the final period, but it's actually the point in time at which you have gone 12 full months, 1 full year without a period.
That's it.
Your menopause. Menopause in and of itself doesn't really cause too many problems. Perimenopause is the real nasty part because that can start up to 4 years or more before the final period, but typically 2 to 4 years before the final period. And it technically continues for about a year after your final period. And at that point, the hormone levels kind of level off again at their new normal. And you start to get, relief from some of these symptoms.
It's 5 years. We're looking at 5 years.
4 to 8 years can be that perimenopausal window. The average is about 7 years for a lot of women.
And are there usually symptoms for most women?
So the perimenopausal period is where the hormones are constantly fluctuating. And this is where you start to see all of the symptoms that women will describe. And about 80% of women will have at least some symptoms associated with the menopause transition, right? So hot flashes, night sweats, skin changes, dry skin, dry eyes. A dry burning tongue can be a symptom of perimenopause. Not a common one, Lanny, don't worry. But it does happen.
I feel like I kind of have some of these.
Well, that's what I was just going to say. How can a woman differentiate between
Monday to me, and dry? Like I feel.
And I remember that was part of the problem. I would go in for these checkups after I had my ovaries removed, and the doctor that I was seeing at the time was like, "Are you tired?
Yes.
Do you experience nightly sweat?" I'm like, is this a symptom of having 4 children and being exhausted, or is this actually a symptom of perimenopause? So
be really hard
how can a woman differentiate between I'm going through something, maybe I need to see my doctor, or this is just life?
Okay, so that's a great question. It's always important to see your doctor because you want to make sure that there's nothing else going on. Thyroid hormones can produce a lot of these symptoms. Thyroid hormones can, if your thyroid's underactive, you can experience weight gain, you can experience hair loss, you can experience dry skin, fatigue, right? It's important to rule that out as a potential cause. It's if your periods suddenly stop or become irregular, and especially if you're on the younger end of things, under age 45, you absolutely
Right.
want to go.
'Cause
and
that's just out of the norm,
investigate.
right? That's
Yeah.
something
Right.
different than
There are other reasons why these things could be happening. So in the absence of another medical cause, we can sort of start to say, hey, could this be perimenopause? And that's where you want to do your homework. I don't say research because I think we use that term now really broadly. Like, I don't even do research as a doctor. I look at the research
Right.
and I do my homework. So if you do your homework, sometimes if you go to your doctor and you just have this constellation of things going on, or you come each time with a different thing.
Literally me. Like I've been
Right?
eating, then yeah.
Right. I think it's perfectly valid to say to your doctor, I've been thinking, I wonder if all of these things could be related to perimenopause. And if your doctor is not comfortable or trained to help you manage those symptoms, for a referral to someone who can. Because I think we have to own this. It can be really vague. We didn't even get below the neck in terms of the symptoms that can happen, right? Like
Right.
there can be low libido, vaginal dryness, palpitations and anxiety, especially at night for no reason, right? And so often women will go and they'll be diagnosed with an anxiety disorder, but it's actually the hormonal fluctuations that are happening in perimenopause that might be causing these symptoms,
Okay.
right?
So I'm curious. So you said you go to your GP if you have these symptoms.
Yeah.
If your GP is kind of like poo-pooing the symptoms or brushing them off, who else, like who do you suggest people go see to
So-
talk to about their hormones?
That's
Or-
a great question. So the Menopause Society, it used to be called the North American Menopause Society. That's where I got my training. They've changed their name now. So they're the Menopause Society. They have a great search tool on their website where you can find a professional who specializes in menopause care in your area.
Cool.
Okay.
The wait times can be long, so start the process early. However, for women who have moderate to severe symptoms, particularly, you really want to advocate for yourself because these are the women we know will benefit the most from treatment, particularly menopause hormone treatment.
Okay. And what is your stance on someone seeing like someone who is in the more natural space, either like a functional medicine doctor
Sure.
or a homeopathic doctor? Do you where do you stand with some of those treatments for perimenopause?
The demand is huge. Women are suffering and they're having doors shut in their face by their doctors saying, I don't know, deal with it. You'll be okay. Everybody gets through it, but they're not functioning at work. They're not functioning with their family. They're losing their marriages. Their lives are falling apart because of these very real symptoms. The supply arose out of that, of people who are like, I can fix you. I can help you. So the term natural is really attractive because it implies sort of that purity and that, you're not doing any harm.
Invasive. It feels like it's less invasive. It feels
Right.
better for you. That's just
Right.
what it, right? Like it's
And
a lesser degree.
I just want people to be very careful because if you're being told you need to have your hormones tested to make sure, that your treatments are on target, that's false. Testing hormones is done in specific circumstances. Lauren, in your example,
Yeah.
for example, in your case, because you were in menopause before 40, the International Menopause Society actually recommends we target your estrogen at a certain level, so between 200 and 400 picomoles per liter. Okay, so I tested your hormone levels because I wanted to see why were you still having such significant symptoms on the dose you were on. Okay, so
And thank God you did, because let's let people know what my levels were.
they were less than 30.
Less than 30, and optimal is
Well, for you, in
For
your
my
case,
age, yeah.
we want to target 200 to 400.
I don't know how I was functioning.
Right. But we
Really
know
well.
that because we know that in women who have menopause
Good job.
prematurely,
alive.
right, they need more estrogen. We're trying
Right.
to almost simulate what you'd be having anyway at your age. And this is to protect your heart, to protect your bones.
Right.
I don't have to keep testing your levels
No.
to know. I go based on how you're feeling. Because after menopause, for the vast majority of women, say you're 55 and you're in menopause, it's totally fine if your level is less than 30 and you're feeling great.
It is fine.
Absolutely. you are not supposed to necessarily have high estrogen levels when you're 60, right? It reaches a new plateau.
Right. Like your body's adjusting to the new
Yes.
age.
So the truth is we go based on how you're feeling. Women who get through menopause with mild symptoms, and they're
it's not
not
like you don't hear about it from everyone.
Exactly.
Or their symptoms are like everything, like a period. That's kind of the point.
Exactly.
So if your symptoms are okay, you would not recommend HRT just because your estrogen is 30
So,
at age 40.
exactly. HRT is indicated it's indicated for people who are either in premature menopause for surgical reasons or just because it just happened to them. It does happen to about 1% of women that they are in menopause before 40. Or for people with moderate to severe hot flashes or high risk of osteoporosis or fracture or severe vaginal dryness. Okay.
I don't know why I laugh every time.
At what, vaginal dryness?
Yeah, because also it just sucks.
Ryan didn't even flinch.
I know.
You're like a child.
I know.
Right? So there are certain reasons to use it, but there are also very, very important reasons not to use it.
Right.
And I fear that some of the so-called natural providers are disregarding that. Their products are not standardized. They are not rigorously tested. Each batch could be completely different. You don't even know what you're getting in that little compounded cream. And you know why? They don't have to give you a little insert that tells you the risks and benefits. Lanny, I want to go back for a second to you.
To vaginal dryness.
You gave a great example with the spironolactone.
Okay.
Right? How you had to have your potassium tested.
Yes.
Because your doctor didn't just say to you, this is awesome, take this, bye. They said, look, this is what it'll probably help with. This is what we're hoping will happen. But these are the potential risks. It can affect your potassium levels because it works on your kidney.
No, for sure. And I did chill on the bananas, and like I moderated my diet a little bit.
There you go.
No, I did it, and it was something I took very seriously. And you kind of like see the Kourtney Kardashians on T, and you just think like, oh, if that's what would be the optimal health is like getting my blood tested. You just it's the way that you perceive that, and it's
so for those who don't know, Kourtney Kardashian was not promoting, but she was getting blood work done every week or every day to test
it seemed like it
her
always on
hormone levels.
Totally unnecessary, ridiculous. They're going to be different every hour, every day, and it probably has nothing to do with what she's putting on her skin.
Right.
I'll give you an example with permission, but anonymously. I had a patient, she's been getting pellet therapy, which is a big unproven. If you Google pellet therapy,
sexy.
I did this myself yesterday. Yeah, you get pellets inserted, hormone pellets under your skin. Okay. And a lot of women are doing this.
Women in their...
And I want to let them know. Women in their 40s, 50s.
Okay.
They go and they get these pellets under their skin of hormones. And if you Google it, you will not come up with a single clinical trial or evidence-based piece of information about this treatment. You will only come up with sales pitches and clinics that are offering
and
it.
all
And what's
these
it
women
supposed to
are
do?
just sticking these
So one
pellets
particular
up there.
woman came to me and she said, there were multiple reasons. She said, I'm sort of paying a fortune to see this person every few months. I'm paying a fortune for these pellets. It's not covered by my insurance. So I'd like to switch to something that's evidence-based, medically supervised. So let's check. We checked her levels. Her testosterone was triple what it should be
Oh, wow.
for a postmenopausal woman. She's like, well, no wonder I have acne and no wonder I'm getting hair on my face. And, and so it was just one example of she had no idea. First of all, the vast majority of women don't need testosterone.
I have so much of it. That's
this is everywhere now, though. Everyone thinks testosterone's the big trend. There's a very small subset of women who all prescribe a tiny dose of testosterone and it's off-label, meaning it's not really indicated, like no one's done a trial and proven that it's going to work or not work, but off-label, we can try it for women where we've sort of optimized their estrogen and progestogen, and we their libido or something is still just really, really low. And so
Sorry, is that why people
give it a
are
little
looking
try.
to get prescribed testosterone?
I
Because
think they don't even know right now why they're looking for it. They just hear
They just
through
hear it as like a
they just
buzzword.
hear,
People
and
give
it's
themselves.
it's really pushed as a miracle cure for everything by their natural health providers.
right.
So yeah, this is the part where I get canceled. No,
No,
I'm
it's not. It's just
trying
so,
to-
I'm like literally testosterone as a woman is like the most negative hormone. You want nothing to do
You'd
with.
be shocked. And
It's like
here's another
symbolizing-
surprising
yeah,
fact,
yeah.
though. Sorry to interrupt
No,
you, but
let's go.
our ovaries continue to produce pretty stable levels of testosterone until we're in our 70s or 80s. So it's another myth that we need testosterone. We continue to produce our own testosterone late into life.
And testosterone. What are the benefits of testosterone?
I mean, certainly give you some energy, help with building your muscle mass, give you some libido. I mean, but we produce much lower levels than men do.
Right.
Like,
Yeah, of course.
There are some good
Right.
benefits. Because I
Yeah.
at one point had very high DHT levels. That's the testosterone hormone. And
Oh, that's when you and Benji. I get it.
I was actually going to say I
Yeah.
can build muscle fairly quickly.
Oh, so it's a flex in two ways: good sex life and
Well, no, but I
biceps.
also have a mustache and acne. There's
Okay.
there's also
There's all
down.
sides.
I'm saying there's also downsides to having a lot
I'm
of
sure you look
testosterone.
beautiful with a mustache.
Thanks.
It
Thank
really
you,
is
Jennifer.
a
Thank
hot
you.
trend.
Yeah. Also, let's talk about a little bit about IUDs because I feel like that's okay. And no one knows
Yeah.
what to do. Okay, most women are a situation.
Yes.
They're either finally off birth control, they're having kids, trying whatever, or now they're stopping. And nobody, if their husband's being a loser, not getting a vasectomy, sorry. And
You don't have to look at me. I had my ovaries removed. I did all the work.
No, that's how I feel. Like, do the work. We've done so much. Like, you're a loser unless you plan on going to have another family. Get your fucking shit dealt with. That's how I feel. But anyways, yeah, she's like,
It's aggressive, but okay.
I kind of just do feel that way. I understand people are scared, but now isn't it like a prick in your like?
Yeah.
It's a prick.
That's the name of my forthcoming book is Get Your Shit Together. So it's a guide for men's vasectomy.
Can Lanny do the opening forward, please?
Yes,
Literally
absolutely.
no problem. So, yeah, losers if you don't, but now back on us that we probably have to deal with it again. Oh, like, yeah, come in me. And now it's my problem, even though I don't want kids. Like, let's just deal with that. Then you have to deal with a condom or an IUD or whatever, or these cups and all this shit. No one wants. What are we doing? What are we girls doing? The mini pill.
Well, it doesn't an IUD affect your hormones as well?
I don't even know. I've just started paying attention to things.
Okay, well,
like
let's,
I've had an IUD just because I didn't want to take the pill anymore. And I thought the mini pill made me crazy.
Okay.
But like,
Well,
I
you know
tested
what?
it out for a few months and I was like, I feel like this isn't for me. But
what, the mini pill?
yeah,
So how's the IUD?
it's been, well, like in terms of how my life's going. No, like, do you know what I mean? Like, it's been very, I
I
feel
don't
like
think it's going to do much for
Before
fixing
you
your
came
life.
here, Lanny asked me if you could remove her IUD. Actually, I was
no,
like,
But-
I'm not going to blame my life. No.
To be educational. Let's do it on camera.
Yeah, no, I was like, no,
Those
full
YouTube
stop.
views
I
would be
haven't
high.
seen my gyno in a year. I'm looking for a new family doctor. And I want to deal with this. I actually think I want it out. I don't think I want my IUD anymore. It's like bothering me. I feel like I actually just like don't like the idea of having these hormones in my body anymore.
Oh, okay. Well, I want to set the record straight.
Okay.
So the mini pill is
Okay.
a progesterone. I'm going to use the word
Okay.
progesterone, although technically we use progestogen for progesterone that we take in as in a synthetic form.
Okay.
So when you take it as a pill,
Yeah.
it's affecting your whole body.
Right.
And it is not unusual for women to experience some mood symptoms, some mild acne, which is like probably the last thing you need, and just breast tenderness, other things that can come from those side effects. The beauty of the IUD is almost all of that hormone is only acting on your uterus.
Localized.
It's localized. It's localized.
not coursing through your veins.
Localized, baby. It's all
How-
concentrated into that area. Okay.
Exactly. It's rare but not impossible to have some side effects through your body from an IUD. But I also want to tell women,
Yeah.
because not everyone's aware of this.
Okay.
So there's the Mirena,
And there's copper.
there's copper, but there's something called Kylena.
What?
Which is a lower dose progestogen eluting IUD. And a lot of women don't realize that. A lot of doctors default to the Mirena. It's tends to cause, women to stop having their periods,
Yeah.
which a lot of women really like. Or if you're having heavy periods, the Mirena is probably better for you. The Kyleena is a really good option. It's a lower dose of the same. So it's the same idea, but it's a lower dose. It's about half the dose.
Okay.
So what you're experiencing may or may not be due to your IUD.
No,
but
I
it
don't
would be
think
worth.
my life circumstances are all surrounding my IUD. I just am kind of at that stage where I don't want to have hormones in my body, right? Additional hormones
Okay.
right now in my body. I'm just kind of feeling like I don't want it anymore. So what's a good alternative?
Well, I mean, if you for copper IUD is a good alternative. If you
No, what if I don't want? I could just
it
go.
doesn't have any hormones.
So that's just how does that work then? The copper
Yeah,
IUD.
so copper is a natural spermicide, and the presence of the IUD in your uterus sort of prevents.
No way. Did you know that's how it
Implantation.
worked? I didn't realize because that copper,
Part of
the
it.
copper itself is what's keeping the sperm to
Yeah.
die. Got it.
So as long as you don't have a copper allergy, it's pretty safe.
Okay. And the hormones IUD work that they're releasing certain hormones so that you don't ovulate.
Well, no.
No, so sorry that
Actually,
you don't.
they don't affect your ovaries at all.
Okay.
It keeps the lining of your uterus really, really thin. So it's not habitable to an embryo.
It thins it out.
So maybe you should switch to that.
No, that's what's happening because of my IUD. It's
Yeah.
making it thin so that I don't get my periods. Okay, this is really interesting. Okay, so if I didn't want to have an IUD at all,
I mean, I think then you're
I
looking
think that's
at
a condom.
a barrier method or a very nice man who gets his shit together.
Because you don't want to go on the pill, right? That defeats the purpose.
Well,
Then you're
I mean,
ingesting hormones.
That's more
yeah, I
hormones.
guess, okay, if you don't want hormones, all you're doing is copper. If you don't want hormones, it's copper, condom, pull out, cup.
I do not advocate the pull-out method. I want to make it very clear you can get pregnant up to a full year after your final period.
You can what?
You can
what?
still get pregnant up to a full year after your final period.
Wait, what?
So until you reach that menopause,
Oh, that's a good trick.
no, not in your case, Lauren.
I'm
Not in
I'm
your
like,
case.
not
oh my,
you.
no, mine would be
No,
immaculate
absolutely
conception.
not.
That's like
when a
in-
man gets a
but-
vasectomy.
No, that's like in that movie, my favorite movie, Father of the Bride Part 2, when she gets pregnant with her mom. And they're both, you know what I'm talking about? And you're like, how are you pregnant with your mom? This is so weird. But Annie's so little looking, you know? And,
Yeah, and I think the mom's really 40. She just like Diane Keaton
but
looks
she's
older at
gray
that time.
already, isn't she? So
No,
it's
she's
a little.
probably 50.
Yeah.
Anyways,
It happens. It happens. Everyone's heard those stories, right? About
Yeah.
I didn't think I could get pregnant. I'm shocked at how many women I talk to who think that they can't get pregnant. I'm
Yeah.
like, you can absolutely get
Okay,
pregnant.
so let's maybe talk about that too. Hormones pre-pregnancy.
Yeah.
Having people a little more educated, not being so reactive. That's at least how I feel. I'm very reactive. I'm like, don't like. I'm not like.
well, I was going to talk about this. So if a woman like say her periods are irregular, I don't know why, but it seems like now like POS is like a very big topic. Polycystic ovary
ovaries.
syndrome.
Oh, yeah,
So many women
PCOS.
have that, endometriosis, like
Yes.
all this like gynecological stuff that I don't know if it just was like we weren't talking about it before, so now we are, or that more women are getting it. But maybe you can talk to us a bit about if we are in your 20s or early 30s and you have these irregular periods, maybe POS, maybe endometriosis. How do you know if you have it? How does that affect you for pregnancy? Like again, to Laney's point, just being more aware now
yes.
for those symptoms and what a woman should look for.
Absolutely. So I guess it's important to kind of know the normal. You know, your normal, your cycles should be relatively normal. Okay. So about 20, let's say 25 to 31 days, 32 days on average for a typical cycle. But whatever is your normal is your normal.
Right.
And you should be, if you're ovulating and then having a period, this should be happening at fairly consistent intervals.
From a young age.
Through your 20s.
Right.
Not as a teenager necessarily, because
Right.
everything's sort of warming up and
Okay.
it's kind of like the opposite of menopause in the sense that it's like sort of finding its stable level. And then through most of your 20s and 30s, it should be relatively stable. I would not say that it's normal to have extremely heavy, extremely irregular, or extremely painful periods. these could certainly be signs that something needs to be investigated. So polycystic ovary syndrome, let's call it, is because you can have polycystic ovaries without having the syndrome. So this is where, just to keep it really like accessible in accessible terms, but every time you ovulate each month, one of your ovaries will give off an egg, right? It can leave a little pocket there that usually dissolves again.
Is that discharge?
No, in the ovary.
Oh.
I hope not.
Just wondering.
So it gives off a little, so that egg gets released.
Okay.
It leaves a little pocket where the egg was, and then it goes away. Some women, it doesn't go away. They keep accumulating these little pockets, and they fill with fluid. And then their ovaries become larger to accommodate all of these little cysts, right? Which is a fluid-filled pocket. And this starts to cause some serious disruption.
And that can lead to
the ovarian organization,
and that, like you said, can lead to painful periods, heavy.
Well,
Sometimes
mostly
you can have
what
some and it's not a big deal. Like there's a few and they're like, we'll monitor them or we'll watch them, and it's
what women with PCO usually notice is irregular periods.
Okay,
they'll go long intervals between periods. Often it's a longer stretch. They'll say, "Well, I only get a period every 40 days," or sometimes I get it, sometimes I don't. So, because it's erratic.
That's how I feel on the IUD actually, which is why I don't like it. My periods were also kind of chill, and I went on this just as an alternative, birth control. And it's I like to know. I'm like I don't like not knowing, and then I randomly get it, so I don't feel prepared.
Can I ask how old are you?
I'm 38.
Okay, so part of the reason that probably is happening is the IUD does not do it. Your ovaries woke back up. So after being on the pill, your ovaries woke back up.
Okay.
And they're starting to ovulate again. But in your late 30s, early 40s, that's where we start to get a bit of irregular ovulation.
Okay.
It's tickety boom sort of through your 20s and 30s for the most part, for most women. Then we start to get into this little bit of some months you might ovulate, some months you might not. Some months you might give off 2 eggs. Some months you might give off 1 egg.
I was a little lazy.
It's just
kind of sloppy down there. Releasing 2? I don't want twins.
Yeah, things are fluctuating a little bit.
They say twins with older.
twins and older women.
No, it's legit. Your ovaries get like lazy. No, they do. They're kind of like, right? Like they're not as tight and cute as they used to
going
be.
on a business sale.
Yeah, it's like, I'm like, this is on discount.
Sometimes it's 2 for 1.
Yeah, it's just like
going out of business
one
sale.
left. Let's just get it out the door, and there you got a brother.
But the painful periods. Oh, and so for women with PCOS, they sometimes get things like insulin resistance, obesity. There start to become there's an impact of that ovarian function on the rest of their metabolism. So they can start to get this sort of metabolic syndrome where their triglycerides go up, their sugars go up.
Are those thyroid related things too, or
No,
that's
this is
completely different?
all related.
That's just related to the cysts on the ovaries.
Got it. Right, it starts to create problems
in your
body.
So look out for periods that, like you said, are maybe not consistent, and then additional things like weight gain.
And you can always get it checked on an ultrasound, can't you? Like if you need to, if you're uncomfortable, you can advocate for that.
There's several ways it can be diagnosed.
Yeah.
It is oftentimes it can be picked up on an ultrasound. They'll see the little cysts. Not always.
Right.
There is a blood test that can be done, that can be suggestive of it. But again, there's no slam dunk diagnosis. It's usually a clinical diagnosis. The doctor will look at all of the different parameters, rule out something like a thyroid disorder, and then they can help you. And usually one of the mainstay treatments of PCOS is a birth control pill, because you want to quiet the ovaries down, stop that cyst production, regulate the hormones.
Okay.
Now, painful periods is suggestive of endometriosis. Endometriosis is a condition in which little pieces of like the lining of the uterus, which is very estrogen sensitive, develop outside of the uterus. So they can develop in elsewhere in the pelvis, on the bladder, on the bowel. So think about that uterine cramping, and that when your estrogen levels
something
go
where
up,
it shouldn't be necessarily.
Exactly.
Is it get infected or something, or is it just like it's not right because the body's like sending stuff there that it's like, why are you here?
Exactly. You have parts of the body that are really sensitive to your estrogen estrogen levels that shouldn't be.
Have it there. Got it. Okay. It's so okay, but this is, I think, a really one important question that I think so many people or new moms or people that are trying to get pregnant. This is like a burning question. Okay, it's all about their hormones, right? Like you're always trying to figure out the right level of hormones before you go to get pregnant because it's all like synced with your ovulation. And you know, I have the Oura ring now that like takes your body temperature, which is tells you right because you need to know those specific type of details. So what do you suggest that
Well,
like
only if you're going through fertility treatment,
right? But even to be like, for example, more educated. I remember trying with my first and not having the ovulation sticks and just like realizing I could be doing things a lot more efficiently. To be honest, like you could be strategic when you're having sex if you understand your body. You know when you're like, you know, you don't have like you at the beginning you have sex all week because you like don't feel like now that we know more, I feel like you can kind of like use that science as a tool to really help you. And I think a lot of people like myself, where fertility journey is completely out of their control, the things that are in their control, they want to be doing. And hormones is such a big part of that. Like I miscarried before every kid I had. So I typically took progesterone before and I would either take it orally or vaginally to help promote that. And I don't think that there was 100% studies that said one way or the other that it would. But it just made it more cushy, is how he explained it in there. He's like, "Don't you want a cushy lining?" I'm like, "Sounds nice, sure." Like, it just
you want to know how to like optimize your body or your hormones if you can in your 20s.
What
to
you
prepare.
need to know to go into this to feel I know enough at least about myself, so I can advocate for myself when I finally get to the gyno or when I go to have the doctor, the conversation with my family doctor that I'm going off birth control. Like, what do I do now?
So I think what you want to do, and I'm answering this from the perspective of a family physician, because obviously I'm not a fertility specialist, right? Or an obstetrician.
Yeah.
But believe it or not, it's not that you have to be Kourtney Kardashianing it and be testing your hormones constantly. But there are certain key principles and they're lifestyle related. A lot of, evidence out there suggests that a healthy body mass index, typically 22 to 23 as a body mass index, is optimal for achieving pregnancy. Not overdoing it with the sex. It shouldn't be every day because you'll deplete the sperm count,
quality, all that.
So you want to know, you do want to track your periods, to know when your ovulatory window is, and that's when you can be strategic and say every other day. During that 6-day window, you have intercourse.
Not doubling up. What's it, doubling up? Ever that? Sometimes you go morning and night
with
thinking,
oh,
that would be, you know what? Different
might have more chances.
Double the chance, double the fun.
No, don't double up. That's unless you want to, but that second time is just sort of like
always
for
used to
fun.
do this, like put the legs in the air and you lie backwards and you lie there for like 10 minutes.
I don't think anyone's put any money into studies for that, but if that
the move, everyone did it.
You wait. You let it
simmer.
Incubate.
Well, let it simmer.
Yeah.
I thought it was like swimming. I was like helping, like it's like if they were swimming straight versus swimming on an angle.
Right.
Like
How
I was
to Get
giving them like
Pregnant
on the
by
slide.
Lanny Levy.
On the slide. Let's go. Give them an angle.
I've been looking at some studies recently. I'm going to be doing a talk soon for a group of dietitians who want to kind of know the impact of diet on menopause symptoms.
Oh,
yeah.
Okay, so
I was just going to ask about eggs too.
Okay. Well, if I extrapolate from this, what I've read, a lot of the diets that seem to have the most impact on at least stabilizing your hormones from a symptom perspective are largely plant-based.
Sorry, plant-based diets are good.
Mm-hmm.
Okay, so
they do seem to have a somewhat meaningful impact on women in menopause and their symptoms of hormonal fluctuations.
And is that women who are not on any kind of additional,
Correct,
like HRT or anything like
Correct.
that? So then I guess in terms, because this was going to be my question, in terms of outside things for your lifestyle, like coffee, like alcohol, like chicken. Eggs, I've heard, are like the worst for your hormones.
People are like, if you have eggs, they say eggs is the best thing for protein. You should have eggs every day, free range, blah, blah, blah. And then it's like, there's so much estrogen in eggs. The fact that you're eating 2 a day is horrible for you.
Okay, where did you hear this?
Yeah.
Where did I hear what? All the time? Isn't that common?
Chicken and the egg thing.
Chicken, I haven't heard as much, but eggs I keep hearing because of the stage that the egg is at. It's like it is full of hormones and supposedly not great for your hormone levels.
I mean, I've never heard this.
We're literally making it up. Facts.
No,
versus
I think someone's making it up.
Or coffee. Like caffeine is it?
For example, or chicken. Chicken, say everyone says in chicken, right? There's so many hormones in chicken right now.
I do think there are hormone-free options for
you can get hormone-free poultry.
That
nitrate-free is hormone-free.
No, again, I haven't
organic.
I haven't seen a lot of research in this area. It just seems sort of logical to me. I know I'm saying this as a mom and not as a doctor per se, but when my kids got to be sort of preteen years, I really started looking at what I was buying in terms of our protein sources. And I did switch to hormone-free options because I just didn't feel... It's the first time it kind of entered my consciousness.
No, for sure.
Of like, I don't think we do know. Therefore, I think I'm going to reduce the amount of hormone that I'm taking in. With eggs, I haven't heard this. I haven't read this. I eat eggs. I mean, I think
we made that one up, maybe.
But you don't have to accept that the entire second half of your life is going to be mired in, dry vagina and pain.
Yeah, like I like KY jelly and hip pain the rest of my life. I'm like, fuck that.
No.
Okay, so
and I think with all that external stuff, it's probably like you see how you react to things. Like, I mean, I cut out coffee. I did not notice a huge difference in my skin or anything other than the fact that I was miserable. So I'm like, screw that. I'm bringing it back. Same with eggs. It's like one of those things that it's like, cut it. I know. I'm too obsessed with eggs to cut them out. But it's, again, one of those things you probably have to see individually how it's affecting you.
I don't think you have to cut them out. And often things can be a trigger for one person that aren't a trigger for another.
I think that's the main takeaway. And I think that's actually a really good place to like kind of sum this up because we've had so many good kind of bullets about like there's so many general things, but I think the main thing here with this, because there isn't a lot of science on it yet, and there's clearly people you should be going to be asking these right questions, and your family doctors should know more a little bit about this if you're advocating, but it's to understand your own body because what's happening in Lauren's body is clearly completely different. So when I'm looking at someone that's doing this online or like, because Lauren's speaking, it's like, that doesn't matter for me. And this is so individualistic. Like, we might both have a high testosterone levels, but we're going through real different shit.
Yeah.
And like people just have to, if they want to, I think it's like just taking whatever that means to explore.
Yeah. And even more importantly, your body may react to a higher testosterone level completely different than Lauren's.
Like, so it's like
she
we're not going to
know because there's just no problem.
Yeah.
I think the other thing, the big takeaway is the period thing. Like, I think for so long, like we were told growing up, it's like, if you have cramps or if you're, if you're heavier that time of the month, that's normal. That's clearly not normal. And these are signs like if your periods are spread apart, maybe you do have, PCO, or if your periods are very painful, maybe you do have endometriosis. Right. Like those, honestly, if you have a younger daughter and she's suffering from that, then there might be a reason around it. It's not just like deal with it.
No,
That's
I've had
normal.
friends that have like that had crippling periods.
Yeah.
And it's like obviously something's going on. Like you have to get to the bottom of it. Like that's not average and there's your body's reacting to something,
You shouldn't be missing school or missing work or missing social functions.
Something's going on.
Because of your periods. Right. If that is happening on a consistent basis, you should go and get yourself checked. I'm not inviting myself back, but like if you find people have, this is what I did with Medcan. People had a ton of questions after my first. And we just did a Q&A as like a whole other.
Okay. So I actually feel like that's a really good thing. So we're going to.
You might get a ton of questions.
Yeah.
There's so much we didn't cover. We can't go on for 5 hours.
So then I think that was amazing. That was so, honestly, I learned so much in this episode.
Same.
I do think we're going to get a million questions. So I think if you're up for it, next time we'll have you back and we'll do a full, just hour-long Q&A.
That'd be really cool.
Absolutely.
right?
Yeah, we'll see what comes in and we can we'll take it from there. But there's gonna be specific questions too. So we'll see how to, you know what I mean? Because this is
Absolutely.
such one of those things that everyone's gonna be like, my circumstance.
And I want to
100%.
give women an opportunity to get answers from someone who's evidence-based, right? Because that is just doesn't
Well, maybe the
exist
best
out
method
there.
is people sending questions and we can ask. We'll figure it out. But anyway, send in stuff. You're obviously here to help, which is amazing. And thank you for this. This was so
Of course,
informative.
it's been such a pleasure. Thank you for having me.
Oh, thanks,
Thank you.
Jennifer.